So again, we're talking about segmentation today, and I'm going to hand it over to Christina Clark to take us through the next little bit. Is this you, Christina? Did I get this right?
Sure, can be.
Okay, thanks.
Okay, so I'm just going to talk a little bit about sort of overarching principles for segmentation, because I think what I've observed is that segmentation is sometimes in some cases a new word for folks. And I just really want to start by demystifying segmentation if it is new to you. So really, segmentation for the purposes of population health management is really focused on, it's a process, and it's a process of understanding why the health of different groups in your population is maybe not optimal. And so when you're doing segmentation, you'll be using data, but you'll also be using knowledge, local knowledge of processes, of your context, of patient factors. So I've written here systems, processes, medical care, and patient factors, and how all of these things come together to influence those outcomes. So data is great, and we're going to talk a little bit about it, but you really do also need to match that with knowledge. And a really good example of this is if you take this down, you have population level data, but you take it down to the care team level. And Mrs. Smith is 79 years old, and you know that she has mild frailty, she's managing well, she also has diabetes, and that's well managed. However, the care team also knows that she just lost her husband, and her nearest caregiver is 2 hours away. And so that changes sort of the risk that Mrs. Smith faces, and it potentially changes how the care team organizes resources and care to care for her during that period. Next slide, please. And so the process of segmentation, what is the purpose of it? It's really to help us challenge our assumptions and act on the data we have, but also the knowledge. It's to support planning to better manage our finite resources in the health system to the specific needs of our populations. It also helps us to identify what are our improvement opportunities so that we can change our processes. We can change how different aspects of our system interact. And then, of course, to understand and account for variations in populations. So we know that even when we take a segment or a group within our population and begin to understand it, so if we thought about everyone with 3 or more chronic conditions, there's going to be still a lot of variation within that population. We talked about material deprivation, social determinants of health, different groups with attached versus unattached patients. Different groups may need within that subpopulation different interventions to help them to each achieve optimal health. Next slide, please. Okay, and so like a Yogi Berra quote, I don't like to quote New York Yankees often, but he's always got a few good ones in his sleeve. And so I love this quote: "We're lost, but we're making good time." And so I think there's so much data out there. It's sometimes confusing what you've got. It's confusing what sources are in it, what's missing. And there's lots of challenges with data as well in terms of it's imperfect. And so in some cases we're lost, but we're making good time. But in some cases we're lost and we're really bogged down in the weeds. So here's just a few overarching principles that I hope will help you to move through the process of segmentation. Next slide. So, and I also want you to think about, Christina Southey is going to talk about applying segmentation to a frail older adult population. And then Lauren Tessier is going to speak about their experience with segmentation in Chatham-Kent. And so think about, listen for these principles. Which principles did they use? And what other principles did you not hear me talk about that they also use? And so the first principle is really about prioritize learning about your population. There are a lot of different approaches to take with segmentation. And I think as long as you prioritize learning about your population to drive care model co-design, keep that as your North Star, you're going to be on the right track. The second principle is look for leverage points in your population data. And I see this, and it's not always clear what these leverage points are. And often we start with the most costly conditions, the highest risk groups. And this can actually be a good approach, but it really has to be connected to upstream strategies that seek to prevent avoidable costs, avoidable mortality, avoidable morbidity. And so this is a really key aspect of population health management, and being clinically and financially accountable for a population to keep them healthy, and supporting people to manage their chronic conditions before they get out of control. Start small, learn and grow, and improve over time. You really don't need to build the perfect segmentation approach right off the bat. Wherever you start is just fine, and it will help you learn, improve. And as you move from sort of your initial population or your priority population to your other populations, and ultimately your whole attributable population, you'll scale up, hopefully, a better segmentation approach from what you've learned. And that's connected to don't let perfect be the enemy of good enough. Same as I just spoke about. It's especially true if you're thinking about some of the more advanced and potentially costly systems for segmentation. So then, of course, steal and share, and credit teams you steal and share from. But there's lots of OHTs that have been on this path for a fairly long time, and they have work plans, they have driver diagrams, they have experiences with using some of this data, strategic plans, and a lot of ideas that might be helpful so you don't have to start from scratch. And then finally, segmentation is a process, not an outcome or an end point. It's not something you'll do only once. It's a model you're going to build, and you're going to use it continuously. So you'll also need to develop systems that will enable this learning over time, and then connect these to your quality planning, your quality improvement, and your quality control cycles. Okay, next slide. And so just a couple of strategies for segmentation, not an exhaustive list whatsoever, but thinking about scope. And you'll have thought a little bit about this when you submitted your application. Where are we starting with? Most folks have been guided to start with a priority population. So that's a subpopulation from your whole attributed population. And then when you start moving into care model co-design, you may even be breaking off aspects of that subpopulation into smaller subpopulations. Also, to think about what data you have available now. We talked a little bit about some of those sources. I think Christina Saudi is going to speak a little bit more, but there's been a lot of data reports that have been shared. The HSPN OHT indicator report. There's also the HSPN segmentation reports, which are being shared this month. And then we have the Inspire primary care data reports, which are available. And we've got, and I know OHTs have access to the OHFSA postal code level data. And then don't forget about whatever local data you have as well, quantitative, qualitative feedback through surveys and interviews, data from partners. Lots of OHTs have started with a partner who's got data to bring to the table, whether it's primary care, hospital, community mental health, public health, and others. So start with what you have available now. And then segment based on what you already know from the population. And this could be quality standards. It could be, where your data point, what directions your data points you in, whether it's material deprivation or attachment rates. So just start with what you already know about the population. Next slide. Okay, and Christina Saudi, take it from here.
Thank you, other Christina.
Can we pause for questions? Do we do that?
Sure, yeah, let's pause for questions. Is there any questions?
Seamless transition. Any questions? I'm looking through the chat. I don't see anything. For folks that have kind of been on this path a little while, how does this resonate? Okay, stunned into silence. Christina, I'll let you keep going.
It resonates.
Yay!
I feel like we shared the link to the Inspire data, and if it were me, I'd be knees deep into a spreadsheet right now while you were talking. So I can't blame anybody if they're also knees deep into a spreadsheet while you're talking. And actually, it might not make sense based on the fact that we're about to do a little bit of an application conversation on frail seniors. So yeah, go to the next slide. Sure, let's keep it rolling. So in terms, this is, yeah, it's new to a great many of you. Totally, Monroe, absolutely. And you know, I was having a conversation with a team, cohort 3 team this week, and one of the things that is true for you that was not true for a number of for cohort 1 and 2 teams is that you have a lot more data sources available to you at this point in your journey than some of our earlier teams did. That's a blessing because it gives you a little more meat to chew on as you're looking at where might we want to focus, or what are some of the segments that we can impact within our priority population, and is a lot more stuff being thrown at you to digest at the same time that you're doing all the other work of starting up an OHT. So it's like it's that blessing and a curse, right? And figuring out a way to move forward and not get overwhelmed is definitely part of that. So in terms of, here's an example around how these concepts can apply within a priority population of older adults. So of course, what Christina just mentioned, you have your attributed population, and then you've all been asked to identify priority populations within that. And on the screen in that number 2 box, you'll see a number of the priority populations that we know that folks have identified, a common one being older adults, given some of the CQIP focus around ALC, those who might not have had a focus on older adults likely do now. And then within older adults, we also know that there are subpopulations within that priority population around those living with chronic condition, older adults who are living in poverty, those who are unattached, and then also the frail elderly, which is a common sort of subpopulation that we know that OHTs have focused in on. So if we take that subpopulation of frail older adults, we go to the next slide. One of the things that we then want to think about is what are the sort of different level groups of risk groups, the different even subgroups within that group of frail elderly that might drive some of the considerations that we have around care model design. So one of the ways in which to do this, and those of you who have already done care or looked at examination of a frail older adult population might know of the clinical frailty scale, but needless to say, there are a number of different ways, examples out there of ways that you can kind of classify frail older adults into buckets of risk that then relate into some of the strategies that we can approach in being able to best support these individuals. The clinical frailty scale is one of those, and it does a good job of being able to sort of categorize people into different levels of frailty that based on sort of the severity of the frailty and then resultant medical complexity. So 0 to 3 being healthy, 4 to 6 being your rising risk, 7 to 8 being more moderately to severely frail, and CFS9 being more severely frail and approaching end of life. Now, if you think about this group, one of the next conversations that we'll have as an OHT is, well, where do we want to focus? Where does some of the need exist within our population? Where might we see some of the gaps in care where we could be intervening as an OHT, but we're consistently missing people? And so if you go to the next slide. What often will come up as this is where we might be needing some of the expert advice and the sense of those who are experts in frailty would be around how do we start to identify and target those who are at a rising risk of frailty, mild to moderate frailty, often missed by some of our existing clinical processes, but very amenable to support and intervention within this population. So we've now gone from our priority population to a subpopulation in our priority population based on maybe you look at your Inspire data and you look at the number of frail older adults that are showing up in ED, or frail older adults that are ending up ALC. And so we decide we're going to look at frailty, and now we have to decide as it comes to frailty, what specifically are we going to look at? And we've decided we want to look at early detection and early intervention as a way to be able to keep people out of the ED and keep people at home longer with the highest quality of life. So if we go to the next slide. So this is where we start to get into what we know about this population, as Christina Clark was saying earlier. We start to find out, do we even know, do we have a way of being able to identify people who are at mild to moderate frailty? Likely not, actually, because it's something that there aren't necessarily well-established processes to do that within primary care or elsewhere. Do we know about what some of the health status, what some of the common conditions are that folks are managing within this population? Do we know anything about their experience of care? What is going well? What could be better? Can we get some insights into utilization potentially from some of the data sources that we have? And then we can also look at more universal data we have available to us that might get an indication of scope and scale. So there's data that we can pull on that looks at the relative frequency of frailty in our population based on age group. As I said, we can bring up the sources like the Inspire Frailty sub-tab. So if you go into that data, there's a sub-tab on frailty. And it actually gives you a breakdown of ED admissions, those showing up in ED, inpatient admissions. It gives you a breakdown of those who are seeing their doctors more than 5 times a year. So you start to get a sense of what are some of the utilization patterns that exist within this population that we might be able to leverage as we start thinking about what can we do to be able to support these people in the best possible way. And then, of course, there's likely a whole slew of insight that exists from those within your community, too, who are already working within this space: home care, primary care, hospital, specialty, community paramedics that are likely seeing folks within the course of their work who might have some insight to share around what are some of the trends in this population, what are some of the needs that we might be able to address. And then there's also going to be information that we don't have. I'm not done. Don't have that we want to be able to address, and things that are going to be part of the work we do moving forward, so that as we are at a certain place now with the data we have, and likely there's more data that we'd like to have in the future, and we start building that moving forward and not waiting for it to make a decision, but building that better future as we alongside start to look at better support for these patients. So how can we start to proactively identify people in a primary or community care environment? How can we start to support people around creating registries for older adults so that we can better sort of track the health and the care needs for these individuals? How are we integrating qualitative data into this from patients as well as caregivers, and understanding different socioeconomic factors and collecting that data for older adults in our community? Now you can change the slide. So where might you start? Now, I've already talked about a number of these, and Christina Clark talked about them in her presentation. But you now have a number of these resources available. Yeah, great, nice. Yeah, Lauren, thank you, Lauren, for chiming in there. Available to you, that as you and your group come together, your working groups come together and start to digest some of the data, there's specific pieces that'll give you insight. So in the OH dashboard, by postal code, there is a indication of the percent of older adults, right? If you're looking at geographically, if we're going to do community-based strategy, where might we want to focus? There's some insight there. There's also insight into material deprivation. So if we're looking at opportunities for low-income older adults, if you've got someone a material deprivation of a 5 with a high percentage of older adults, that's going to be potentially a community to start off with as we look at being able to look at how we can support individuals. If you look at the Inspire data as well as the HSPN reports, it'll tell you where folks are showing up in terms of primary care setting. And that allows us to be able to ask questions around if the majority of our frail seniors are attached to family health teams or not attached to family health teams. How are some of those settings represented in our partners, and how are we reaching out to involve them in our work? There's information there around people showing up to ED or admitted. So there's conversations we can have around what happens when someone who's determined to be frail older adult, or even who is 75 plus and comes in with a fall. They may not be noted as frail, but that might be a warning sign. What happens, and what might be the area of opportunity within there? And then, of course, sometimes we have folks that put up their hand and say, I want to be involved in this journey. I have some passion here. And how can we start with them to learn and test some new ideas? Next slide. And so with that, I'm going to should we just roll right into Lauren, or see if there's any questions at this point, Mike? Because I think Lauren has a good application example.
Yeah, let's hear from Lauren, and then we have time for discussion at the end of that. So I'd like to introduce to you Lauren Tessier. She is one of the Impact Fellows that there are, I believe, 12 of them right now and another cohort coming on who are also supporting the OHTs in a variety of different roles, depending on what their project work is with the OHT. Lauren is working with Chatham-Kent and has an excellent example of what it was like doing segmentation work with this particular OHT. So Lauren, I'll hand it over to you. If I missed anything critical in your bio, please fill in the details. Thanks.
Thanks, Mike. You can go to the next slide, Liz. Thank you. So before I get started talking about our segmentation experience within Chatham-Kent, I think probably maybe an important fact to know about me, or maybe an interesting fact, is I came from an academic background and am now in a fellowship where I very much am working, very much embedded in the team on the front line. So it's been a very interesting and great learning experience for me to go from the academic side of things, where I kind of approached this fellowship knowing what was theoretically possible and what the literature tells you to do in terms of population health management and segmentation. And now having some more on the ground experience, I think it's really rounded out my knowledge, because what I'm about to tell you is very much informed by, again, the decisions that we had to make on the ground and the way that we had to adapt, again, research informed practice to actual practice and to on the ground realities. So with that being said, as Mike had said, I'm the Impact Fellow working with the Chatham-Kent OHT. Chatham-Kent is located in southwestern Ontario. It's kind of described as a community of communities, definitely on the smaller side. Our attributable population is about 105,000 people, and the priority population was defined as individuals aged 55 or older who have one or more of COPD, CHF, angina, diabetes, dementia, and or otherwise complex. So provincially, this is 4+ chronic conditions. And depending on data sources, our priority population is somewhere between 10 and 14,000 individuals, so about 10% of our attributable population. And you can go to the next slide, Leslie. And another important point I will make about our context that was really relevant to our segmentation approach is that we knew from an early point that we did have a really high rate of material deprivation. So this figure is from the HSPN reports that had been disseminated to us. I believe you, as cohort 3s, will likely be receiving similar reports, but the coaches will be able to correct me because I'm not sure. But the point here is that, as Christina and Mike have said, we really tried to utilize all of the data that was made available to us to try to inform our decision making. And this was probably one of the earliest examples of this. So we're OHT 12, which is right here kind of at the top. And so as you can see, out of all OHTs, we have the second highest proportion of our attributable population living in the most deprived area, so Q5. So knowing this, we knew that being mindful of this and somehow incorporating this into our segmentation was going to be really, really critical as we moved forward. You can go to the next slide, Leslie. Okay, so on to our approach and key learnings, and next slide. So the first key learning is that our segmentation had to be iterative and had to be flexible. So I started my fellowship in September, and like I said, I came from an academic background, and what that set me up with was the expectation that segmentation would be a rapid process. I really thought we'd be done in a month tops, and it would be based on linked data with multiple inputs from every individual in the priority population. And so if you have started to have conversations about segmentation, or if you've tried to tried your hand at segmentation, you will know already that this is not the case with the data that you have available to you on the ground. And our reality really was that our segmentation process ended up being lengthy, and there is something to learn from this. So what I mean when I say it was iterative is the segmentation process really started for us in the summer of 2021. And we had data pulled from the hospital and from primary care. And our experience on the ground was at the time that the data was pulled, it kind of culminated in a huge PowerPoint presentation. And there was a bit of a downside to this because while we did have a lot of data, when it was put into the hands of the various working groups and the individuals that actually had to make decisions about that data, they were overwhelmed. And so this is back to Christina's point. It's a bit of a two-edged sword. Having access to more data is in some cases great, but some cases can hold you back if you are using data without a purpose. So segmentation is not data analysis for the sake of data analysis. You really need to have a clear purpose to that data. You need to go into segmentation with very clear questions, and then once you've been able to answer those questions with that data, you are done. You can move on. You don't necessarily need to continue to belabor things because, again, no OHT is working with perfect data, and all you can really do is acknowledge those imperfections at every step of the way, and know that really at this stage of things, what we are really trying to do is practice population health management and just get used to having different people look at data, and then, as I said, use that data to make decisions. The last point I'll make here is that the last point I'll make here, I'm just thinking back on the experience now, is that with respect to moving on, I really thought that, again, based on how segmentation is set out on the literature, I figured we would pull data, analyze it, come up with some more questions, send it back to decision support people. They could pull more data, they could stratify it in different ways, but that didn't happen. And so sometimes you have to, again, this kind of feeds into my next point. You can't really let perfect be the enemy of good. You have to decide when you have enough information, again, to inform those co-design decisions you want to make. So the whole point of segmentation is really to inform co-design, and that's really the point that you're trying to get at. So Leslie, if you could go to the next slide. So what we ended up doing with our priority population is we broke down ACSC hospitalizations and BME visit rates, and that data is not shown, but we broke them both down by diagnosis group, by age, and by material deprivation. In terms of key messaging, even though we had more data than this, when we presented the data to the various working groups and the individuals that had to make decisions, this was the messaging we focused on because, again, we really didn't want to overwhelm people. And so what you'll see here in these tables is that COPD in younger seniors was driving ACSC hospitalizations, and ACSC hospitalizations for COPD were significantly more prevalent in people living in the most deprived quintiles. And so I think the point to make here is your segmentation really doesn't have to be fancy. Like, this was kind of enough to ground people in how to move forward. So out of all of the individuals in our priority population, what the data told us was that it was individuals with COPD who were driving potentially avoidable utilization. And there was enough data here for people to feel comfortable with moving forward. And so this was it. And I think sometimes when you start talking about segmentation and all of the data sources that are available to teams, it can get a little overwhelming. But this is really what I mean. Once you come up with a couple of key questions and you answer those questions, if you can use more data sources that help you answer those questions, that's amazing, but you also don't necessarily have to. It really depends on your context. And again, it depends on who's at the table. If they're comfortable with data, if they're comfortable looking at data versus not, if they need a little more, hand-holding. And then Leslie, if you could go to the next slide. So as I had alluded to before, our second key learning is don't let the perfect be the enemy of good. So again, these are really just points that I think we've all at this point touched on. No data is perfect. The messaging that we adopted was very much focused on what you can learn from your data rather than seeking perfection, and then let your context inform the decisions you make. Next slide, Leslie. So for us, as I had said, a big piece of our segmentation approach was knowing that we had a really high rate of material deprivation. And so in terms of trying to pick a data source for our segmentation efforts, knowing this about our material deprivation really drove our choice of data source. So for our population, older adults with multiple chronic conditions, you may think that the home care data would be a more obvious choice. However, we did decide to go with the hospital data because for us, for the data available through the hospital, they also had material deprivation data available. So that was the easiest way for us to get to that data. And that's what we went with. So again, the data that we use to segment does not capture every individual in our priority population. And of course, it would have been ideal should we have had individual level material deprivation data, but we don't, and we couldn't let not having a perfect data source stop us from using legitimate proxy. And then next slide, Leslie. And then finally, and this was a big learning for us, was don't jump to solutions. And so for us, I will share, like I said, I had started in September, and when I started, for various reasons, and I'm sure a lot of people can relate to this, COVID had significantly delayed a lot of the work that had been started. And so the appetite on the ground was very much one of, we want to move forward, we want to get something done. And again, I can really appreciate that enthusiasm. And I think that type of enthusiasm with this work is really important. But sometimes what that leads to is, again, people jumping to solutions and people jumping to what they're comfortable with, to really relying on anecdote rather than taking the time to slow down, and then looking at your data and using that data to inform decisions. And so I think it's important to remember that if you have not started to segment, it is really never too late. When I started, the team had they had talked about segmentation, but I don't think there really was not the time or the capacity to really ground themselves in a process. And so when I started, we really used that time to pause. We even paused working groups so that segmentation could be done, so that we could really ground ourselves in this evidence-based process. So these figures are really familiar to you, but we very much then became committed to being evidence-based. So we were following this RISE process, and we presented on these figures to the various working groups to really get everybody on the same page about what we were doing and why we were doing it. And this has been really helpful to moving to being at a point now where the work has moved forward, because I've personally definitely seen a change on the ground where now more and more people are familiar with these processes. And it's become a lot more cohesive because everybody understands why we're doing what we're doing. Oh yes, so that's about it. So following this evidence-based process, as I've said, we've decided to focus our co-design of population health management on individuals in our priority population living with COPD. To kind of scope our project, we decided to focus on individuals with mild to moderate to severe COPD who are living in the community. So again, focusing on the severe cases, that's kind of what our data told us. Like, these are the people who are going to the hospital and are for BME visits for ACSC hospitalizations. But we're also kind of extending it to the mild to moderate, again, because the lower you move down in the pyramid, the more opportunity you have to impact your quadruple aim outcomes. And yeah, I'm happy to answer any questions about the process on the ground. Nadia.
Hey, Lauren, thanks. This has been an awesome presentation. I'm curious, you talked about going to all of the different working groups and talking about the data that you're doing. So I'm just from your experience, we're just starting to onboard people to our implementation team now and potentially meeting with a fellow next week. So I'm just curious how you went about trying to tie all of that work together. Because it sounds like there was some work happening behind the scenes on like the data and the segmentation, and then bringing that into the different working groups to help support what I'm sure is already excellent priority populations that they had identified.
Yeah, so it was very much, I mean, Leslie, if you can jump back one slide. We really centered ourselves. Oh, my headphones are dying. We really centered ourselves essentially two figures, and essentially we mapped out what we were going to do to these figures to understand, so people could really visualize again how the work being done fit into an evidence-based process. Does that kind of answer your question, Nadia?
I think, are you talking about the working groups, for example, were they focused on particular populations?
Oh, yes. Okay, perfect. So our working groups, sorry, this is so anecdotal. So we had an integrated care design working group. And then from that, there were 3 sub-working groups, ED avoidance, effective transitions, and I forget the third one. And so something that I will share with you is what we realized as we were doing this work is that inadvertently, the silos that we always talk about wanting to break down were kind of reemerging through all of these different working groups, right? So when you think about population health management, it is kind of integrated care at scale. It's integrated care for entire segments of an entire population. And so the conversations that we started having were, does it make sense to have these 3 sub-working groups focused on all of these different pieces along an integrated care pathway when really everyone we need to ensure that we have the right voices at the table to legitimately break down those silos and actually make sure we're developing integrated care pathways. So we mostly presented this data to the integrated care design working group, who was kind of like at the top, and then the ED avoidance sub-working group. And then the recommendation that ended up coming from this once we landed on co-design was we actually need to pause these working groups and rather assemble a COPD task team that's composed of everybody who's currently along the care pathway of individuals living with COPD in the community. And we found that to be much more effective.
Thank you.
Christina Clark, did you want to sort of expand on your comment in the chat there?
Sure, I was just responding to Nadia's question, hopefully accurately, how OHTs are tying this work, the segmentation and the priority population to their CQIPs. And so I'm sure most folks know that the CQIPs have 2 indicators, ALC days, mental health emergency department first contact rate, and then 3 cancer screening indicators. And so some of the things that I've seen in terms of connecting it to segmentation in the priority population are that the OHT will just focus within those indicators on the priority population. So what can be done as it relates to mammograms and screening there, as it relates to their older adult population. So that's where they'll start, and they'll target that first. And they'll talk about potentially some of the care model plant development they're doing and interventions that they're thinking about testing there. I have also seen some OHTs that have broadened their priority population. So they might be thinking about child and youth mental health and substance use disorders as it relates to the mental health ED first contact, but not every OHT has the capacity to do this. So that's just a few observations of what I've seen in terms of how OHTs are tackling that.
Yeah, and go ahead, Lauren.
Oh, sorry. I was also just going to say in terms of, because Nadia, I'm just seeing your comment now about tying the change initiatives to the CEQIP requirements. So I think it's tough because the CEQIP indicators are at an attributable population level, and they want you to report anticipated changes also at an attributable population level, even though all OHTs are focusing on smaller segments, which obviously translate to smaller changes at a population level. And so what we decided to do with our CEQIP is we said as a group, we want our population health management work to drive our CEQIP. We don't want it really to be the other way around. And so in every capacity possible, we tried to talk about the population health management work that had been done and the co-design work that was going to be starting. So again, our co-design is focused on individuals living with COPD in the community. We're trying to keep those individuals out of hospital, but we also want to have conversations about integrating mental health and addiction screenings into those integrated care pathways. And so for us, our change concept is this co-design piece. And the CEQIP is really meant to be a living document, so you can update it. And so with all this in mind, we said our change concept is the co-design, and change ideas and process indicators that are related to the work that we're doing will emerge once the work has started. But the CEQIP is for the coming fiscal year, which hasn't started. So once that co-design piece actually starts and things start to take shape, we will update our CEQIP accordingly. But we're really not trying to figure out indicators before we started the work. So again, this really goes back to don't jump to solutions. Like if you don't know what you're doing yet, that's fine. That's totally understandable. But you can use a CEQIP to speak to how you're going to set up processes to determine what you're going to be doing.
Yeah, bang on. That's actually in the OHTs that I'm working with. It's exactly that. It's the combination of where our alignment already existed. Awesome. They throw that in there and show how it's impacting. And then the vast majority of their actions and their change ideas for 22, I'm like, what year are we at? 22, 23, are around better understanding with specific indications on how they're going to do that, right? So they're going to work with 3 to 5 primary care offices to better understand current mental health supports in their offices and sort of what their data shows around the mental health needs in their population, with the goal that in 3, 4 and beyond, there'll be targeted initiatives to better support those coming with mild to moderate mental health issues in primary care, right? So it's not like there's some sense of they know what it is they need to know and they need to find out more about, but not pretending like you already have the answers to what might be useful downstream. I also think the fact that those HSPN reports for the CEQIP indicators segmented in a couple different ways are just coming out now is going to greatly shape some of the questions that you have about those segments related to those indicators. So one of the themes that I'm seeing and some of the different ones I've looked at is around cancer screening, low chronic conditions, a high percent of people who are missing a cancer screen, otherwise healthy people who are missing cancer screening, and then some unattached. So you start to ask questions like, if we're seeing people with low or chronic conditions who feasibly are attached and should be seeing us at some point or another. Why is it that we have 40% of them who haven't had a cancer screen? What's happening within that process that maybe we can improve upon? Or if we have a large part of our healthy individuals, maybe they're not coming in for care at a regular interval. What can we do around outreach and more proactive recall mechanisms to keep up to date with cancer screening? And likely these are things you've already been thinking about. But some of those HSPN segmentation reports will allow you to ask better questions in the coming year that will then lead to some of the change ideas or expanding things you're already doing that are working so that they can have a bigger impact with potentially a larger proportion of your population.
We've jumped into our discussion part of this section. So other questions that people have? Other about the work that Lauren's doing with Chatham-Kent or about segmentation in general? Or the CQUIPs for that matter? While people are thinking of their questions, I can't emphasize enough that we don't want the indicator being the tail that wags the dog. It really is, you're looking at the work that needs to be done, and then in your CQUIP report talking about how that will impact the indicator. Another great example that Christina Clark put in the chat was you might find that screening for, or that depression is a real issue in your OHT. In the East Ottawa, they pulled some hospital data and found that 50% of ED visits were for depression and anxiety. So where that's taking them is we need to start doing some depression screening in primary care, and so that these folks are getting treated rather than showing up in the ED. Now, is that linked to ED first visit for mental health contact? Maybe, maybe not, but it's the right work to be doing, and ultimately it will impact those indicators.
And I'll just pick up, I know you said don't just to say it, Mike, so I'm just going to say it. I think the hardest one for people has been the ALC indicator.
Yes.
And that's because some of my teams, when they're talking about the ALC indicator, the conversation includes something along the lines of, we've been working on this for years without being able to impact it. Like what is it that we're really going to be able to do? And so the natural next step is, well, what we need to do is better understand the needs of those who are in community and not yet hitting hospital to support them earlier on. And that's not going to impact an ALC indicator in the short term, because those are people that hopefully it's not necessarily focusing on some of those folks that are ending up ALC today. And so there's a little bit of a tension between there's definitely messaging from the ministry around the desire to have OHTs work more upstream, and the appreciation that some of the effects of that work is going to take a number of years to be felt. And OHTs, I think, need to have that own conversation themselves around how comfortable are we with the understanding that this indicator may not move for a year, 2 years, 3 years with upstream work, but over a longer time frame, in the long run, this is going to have a more impact for our population and overall population health. And what are some of the indicators that we have from our community that we can start to hold up that show that we're making a difference for those who are traditionally ending up ALC, which is medically complex, frail elderly, a lot of them. How can we show that what we're doing upstream is making a difference that should be felt later on? So that I think has been a tricky conversation that's been easier to navigate in some groups than in others.
I just wanted to add on to that, and it's connected to what you were saying, Christina Sarli, is that connected to, say, ALC, I've seen lots of OHTs that are focused on a frail older adult population, and they understand that that is one of the drivers when they look at some of the data. That's one of the drivers of the ALC rates, but it's not always clear where to start with that population because there's not consistently or routinely documented frailty information on those individuals. There might be good documentation on their chronic number of chronic conditions, but frailty is not something that they routinely track or collect consistently. And so for some teams, that's sort of what feeds the next step of the co-design is, well, we need to start documenting frailty status for older adults. We need to start doing some case finding, assessment. And so you're kind of simultaneously building the data systems also that will feed additional segmentation and support your work with care model co-design and understanding that population.
I have, along that line, I have a question for the group. Have any of you started working with home care or plan to work with home care with folks that are receiving home care services, but are not in long-term care yet, or could be kept out of long-term care? Anyone having those kind of conversations or wanting to?
It's brute. So not on an OHT, but well, part of the OHT, but through our community paramedic program, we're collecting that data through the community paramedic long-term care funding. But we just started that this year. But yeah, we're doing that, trying to keep people in their home, keep them out of long-term care, or bridging that gap for home care.
That's terrific. And you're part of which OHT?
So we're the Windsor-Essex, part of the Windsor-Essex OHT.
Oh, that's right. Yeah. So again, if we think about ALC days, this kind of work, while it may seem very upstream, will ultimately impact ALC days, because a lot of those folks, if they show up in the ED or get inpatient admission, there's the paramedic program working with home care to make sure that they stay at home. So again, when you're thinking about your CQIPs, you don't need to necessarily come up with an intervention or a model that fits right to the indicator. It's fine to talk about the current work that you're doing and how it might impact the indicator down the road. Hope that's clear to folks. Okay, I know there was a couple more slides. Lauren, did you want to finish your last slide? I realized we sort of cut you off.
No, it's okay. I had already spoken to this. I mean, maybe something else I'll add on in case it resonates with anybody. The decision to focus on COPD for us, again, was both data driven, but also strategic. So the data told us that it was individuals with COPD who were driving, again, a lot of that potentially avoidable utilization that had been identified as important by some of our committees. But also there is an existing evidence-based program within the Erie St. Clair LHIN called Best Care for individuals with COPD. So this is an evidence-based program. And so again, so the decision was strategic in that we were able to say, again, to the committees, hey, we can build on this program. Like, we're not necessarily just trying to funnel people into this program, again, because the whole point of population health management is really designing integrated care pathways. So we needed more. And again, we do want to explore how you integrate palliative care into these pathways, how you integrate mental health and addiction screening into these pathways. But having something like this that we could build off of, and also the data told us obviously people with COPD are experiencing inequitable outcomes. So there's at some level a lack of standardization. But it was a good starting point to say to people, we have something that we can build off of. And so if there's something similar within your communities or within your OHTs, I mean, that can be an important part of your decision-making process too. So that's, like Christina Clark was saying, it's, the segmentation and the decisions that come from segmentation they rely on data, but they also rely on your community and your OHT context too.
Terrific. Thanks so much, Lauren. Christina, you have this slide. Did you want to just address that, and then we'll let folks have a quick break?
Sure. Did I have this? Yeah. I think we've talked about a lot of this already. Really looking at, so as we break this down to, so what are the take homes for you? These are some of the themes that we've already talked about. Identifying what are some of the questions that you have about your priority populations, or even about subpopulations within that priority population that can drive some of the investigation you do into your data, just like Lauren talked about earlier. So where are people receiving care? How many folks might be within this population? What are some of the needs that we might see emerging within that population? Why are people ending up in ED or in acute? And then recognizing what are the data sources that can give you some insight into these. There might not be able to give you perfect answers, but some insight, and what are the gaps that you're going to have to do some different types of understanding to better answer. So we've already talked about a number of these reports that you can start to explore, and then understanding that there likely will be a need to make that jump down to a more local data source, like a primary care panel or community organization or community paramedics and the information and data they have, and in qualitative data collection or survey-based data collection of those who live in community who would have some insight into the experience of living, or caring for an older adult, a frail older adult, or being a care provider for them. And when those sources are brought together, it paints a really good picture around, okay, we now understand where people are showing up and what some of their needs might be that help us to inform some of the interventions and the care models that we want to be able to adopt or innovate to best meet the needs and help keep people well in community longer. So that's it.